Recording in progress. Let's run it. All right. So again, welcome to PA School Mini Boot Camp Week 1. Again, not a sprint, it's a marathon. So who am I? Why am I speaking to you? I'm a first generation Cambodian American. My parents came here to America, specifically Long Beach, as a refugee from Cambodia from the killing fields. I'm a second generation PA though. My dad went through ESL, Long Beach City College, and became a PA, and so therefore I followed in his footsteps. Um, again, I'm from Long Beach, California. Went to undergrad at UC Riverside, got my bachelor's degree there. Did a post-bac program in Cal State East Bay for a couple years. Applied twice to PA school. Got in my second time to my dream program, which was Marshall B. Ketchum University in Fullerton. Uh, Graduated in 2020 and recently did my doctorate of medical science at the University of Lynchburg, in which I attended my graduation in May. And that was my first ever time setting foot on campus. All right, so introduction to the PA program. So I would hope that everybody here knows at least what a PA is, correct? Awesome. So let me tell you a little bit about our profession and how we came to be. Something else that I want to kind of instill in y'all's mind and mentality and mindset going through this process. You're already halfway there. You've decided that you wanted to be a PA. I want you to put yourself amongst this profession. You might not have the acceptance yet, you might not have the degree yet or title, but consider yourself amongst this family of PAs. Okay. So when you go into interviews and you're answering these questions, right? And they ask you, what is a PA? PAs are X, Y, and Z. Instead of saying they can do this or they're able to do this, right? So we as PAs are able to X, Y, and Z. Have yourself in that mindset and mentality that you're already halfway there, because that way you're manifesting it and putting it in your mind that the work just needs to be done, right? You are already having that mindset of a PA professional. All right. So the birth of our profession. This gentleman right here to the left is Dr. Eugene Steed. Um, he developed the PA profession when 4 Navy corpsmen came back from the Vietnam War, and they were, skilled and had all of this talent and knowledge. However, there was no space for them or profession or occupation for them when they came back from the Vietnam War. And so therefore, Dr. Eugene Steed, he started the first PA program at Duke University in the mid 60s. Graduating class was 1967, in which those 4 corpsmen became the first PAs. And so he thought that this profession would be beneficial in the training of a lot of the doctors during World War II. So when they were short on doctors and healthcare providers and physicians, they pretty much made a fast track of training to train these doctors during World War II. And so that's kind of where he drew the PA curriculum and the training off of that model, I guess. And because of that, we are trained under the medical model, right? So you've heard of that before, know it, understand that we are trained under the medical model versus how nurse practitioners are trained under the nursing model. Okay. So what is a PA? Let's have somebody know right or wrong answers. Just let me hear what your definition is. If you were to explain to somebody what a PA was, what would it be? Go ahead, Sandra.
Okay, so my definition of a PA is a provider who can diagnose, treat, and prescribe to patients, and then they can work in a variety of specialties, and they're also like a mid-level provider.
Okay. Okay. No, great. You brought up some great points again for just practice purposes. I know I called you out on the very first question, but remember, you too, you can do that too, right? You're a PA, right? Well, not right now, but developing that mindset to be one. But thank you for sharing, Sandra. All right, so this is kind of like my quote unquote textbook definition of a PA through PA school training and again interviews and explaining what it is to people. So a PA or a physician assistant, soon to be a physician associate, is a nationally certified state licensed medical professional who practices medicine on a healthcare team in collaboration with a physician colleague. We can take medical histories, examine patients, order and interpret diagnostics in labs, diagnose and treat patients, including prescribing medications, performing minor procedures, assisting in surgery, and providing patient counseling. Right? That kind of sums up what a PA does, right? Or what we're capable of doing, right? All right. So how do I become a PA? So, in order to become a PA is required to proficiently complete prerequisite courses, obtain healthcare and patient care experience, and then apply, as y'all know or you might not know yet, via CASPA, which is the Central Application Service for PA programs, and then attend an accredited PA program. I know I'll get questions with regard to, hey, you know, Professor Hunro, can I go to a provisional accredited PA program? Yes, you can. Technically, you can also go to a probation program, but it's just a lot riskier. Um, if you are able to matriculate and they are on probation, you're still able to sit and take the pants. However, if the program is already on probation and you get in and God forbid they lose their accreditation, then unfortunately you have to find another PA program. So take that into consideration when you are applying to PA programs. Don't just pick the very first one that accepts you. You want to do your due diligence and pick a program that you can trust that will allow you to reach your goals of become a PA. And then finally pass the PANCE, which is the Physician Assistant National Certifying Exam, and finally obtain a state license. And then, down that line, you'll apply to the states where you want to work as a PA and obtain the license from the PA board and all of that. All right. So PA trends, I want to highlight this because as you can see, our cohort right here is very diverse, right? We have a variety of backgrounds. We have a variety of ethnicities, ages. I want to just share something to you. So the PA profession is growing at approximately 6% year over year. So every year there's about 6% more PAs than the next and the next. As you can see, there's so many new PA programs popping up, right? Currently there's over 168. This is, I believe, as of 2022, 2023. So that number might be at about 170,000 practicing PAs. It As some of y'all have seen on social media and on news articles, U.S. News World and Report named us as the #2 healthcare job, just behind nurse practitioners, and with a projected 28% growth over the next 7 years. So, is there room for you? Is there a need for you as a PA? Absolutely. So, I don't want you to be discouraged whether you apply your first, second, third, fourth, or fifth time. Um, the need is there for you as a PA. You just have to dig deep and figure out, why do you want to become a PA? What steps do you have to take from where you're at right now to where you want to be as a PA? Average pay, you're not making NBA money or super baller money, but you make a decent living that puts you in it changes your trajectory and your family's trajectory in life. It is life changing money, but at the same time, it takes a lot of work, and PA school is expensive, but you are compensated well. In comparison with other professions, yeah, you might work a little bit harder than some of the physicians, and they get paid twice, maybe three times as much as you. But you know, I'll talk about this later on. But you don't go in for the money. Just know that you will be compensated well. All right. So as you can see, this trend right here, the number of PAs who were certified for the first time, so new grads essentially, right? Look at the number in 2013 and a decade later, that number is almost double. All right. So we're the PA profession, the word is out there. A lot of folks want to become PAs. A lot of people are applying, and hence why it's a lot more competitive. But you setting yourself apart, you having a strong foundation with your grades, with your hours and your experiences, those all correlate to your path to becoming a PA, right? And then next right here, number of certified PAs. Again, this is about, well, right here it's 5.8%, but about 6% year over year. And oh, over here actually it says 5.8% of PA workforce indicated they have plans to retire in the next 5 years. My dad being one of them, he's trying to retire. So I don't blame them. They've definitely been putting in work, but it's wild that just like a few years back, I think the first PA, or like one of the first four PAs, uh he recently retired, but he also, like, they did a feature on him, how the PA profession has grown since then and changed. um the title has changed numerous times, from physician assistant to physician's assistant to physician associate to back to physician assistant. So regardless of what they call us, we know what we do, right? So don't let the title affect you. Just know that we are here to make a difference. And as you can see right here, the trends, where the PA profession is getting a lot younger. There's a lot more uh, students and applicants applying fresh out of undergrad, or a few years out of undergrad after years of experience. Some people going back to school to become a PA. Left side of the chart right here shows the number of male students versus number of female students, or PAs. And as you can see, it's definitely leaning a lot more towards the, to females wanting to become PAs, and for a majority of reasons. I can't speak on everybody's behalf, but some of the more popular reasons as to why there's an uptick in female applicants is because women want a career in medicine and healthcare as a healthcare provider, but they don't want to go through the years of medical school and residency. And and the PA profession is a great opportunity to allow that. So again, that's just a an example as to why there's an uptake, but nonetheless, everybody has their own reasons, right? So what does the quote unquote typical PA look like? Based on that statistic that we looked at earlier, right? Leaning more towards females and, younger females. A statistic I want to share with y'all is it's about 80 to 83%, I believe, Caucasian. It's in the 80s. I'm pretty sure. I'll get that stat to y'all, but about 80% of PAs are white or Caucasian. I don't want that to discourage anybody, right? So this quote unquote typical PA might look like this, but I want you to be reassured that it's more like this. It's very diverse. It's starting to be diverse, and y'all are gonna, increase that diversity and representation, because representing, the patients that you serve matters as well. And you might not come from that background, but being able to help them and serve them, that's what matters. Growing up, how many of y'all had a primary care provider who was a white male, right? Versus now you see a lot of different ethnicities and different gender of healthcare providers. Uh, a lot of healthcare providers are able to speak multiple languages now, right? So myself, I try my best to, I use medical Spanish literally every day, but I'm not the best at it, but my patients appreciate it, and they are willing to build a better rapport once they know that you're able to provide that care, and you're not just you know we want to rebuild that trust in the healthcare system with our patients, and that comes with trying to create a rapport and trying to create a connection. So whether it's background wise, language wise, whatever it may be, do your best to build that bridge. Okay. All right. So PA School 101. So what is PA School about? What is it like? It's split into two different things. I'm sure y'all have seen this picture or heard of this analogy before, especially those who have shadowed me virtually before. But let's go ahead and have somebody try to explain what this picture is.
I could go for it.
Go for it.
So it's a lot of information all at once, and it doesn't stop. People say like you drown because of it, of how much water is being dumped on you, how much information you're trying to absorb all at once, something like that.
Yeah, no, that's good, Richard. Hopefully nobody drowns, right? But yeah, I mean, figuratively speaking, yes. So what this picture encompasses is PA school is like drinking water out of a fire hydrant, right? Obviously, that sheer amount of volume coming at you so fast, it's going to be not impossible, but it's going to be extremely difficult. Others have done it before, y'all. Just trust the process that you will be able to get through it. At some point, you're going to feel like, wow, how am I expected to know all of this information, or how do I even get through this? You just do it. You rise to the occasion. You step it up, and you're able to, and you'll be surprised by how much information you're able to retain and learn in such a short amount of time. So be proud of yourselves when you are able to get through this. So PA school, like I said, is broken into two different phases. The didactics phase, which is the quote unquote book work or studying. I mean, it's always studying, but most of the book work in this aspect. And then finally, the clinical rotations aspect. So during didactics, you're going through all the clinical medicine modules and clinical medicine lectures, the cardiologies, the physiologies, I mean, cardiologies, pulmonologies, gastroenterology, all the ologies, all the different specialties you're learning about, all the anatomy and physio that goes behind it, are all the pharmacology and pathophysiology that goes behind all the conditions that you're covering. Other lectures might include medical ethics, evidence-based medicine, interprofessional education with other professions who might be on campus with you at that health university. Physical exam skills. So you're learning how to auscultate patients, examine their ears, examine their, reflexes, all the different tools and skills that you need to be prepared for clinical rotations and beyond. Clinical skills and procedures, so being able to do injections, incisions and drainages, suturing. You're learning a lot of that or most of it in didactic year. That way you're well prepared for clinical rotations. Then you're also going to have, most programs will have some type of standardized patient encounter in which, uh, and a quote unquote actor or volunteer comes in, pretends to be a patient, and this is your patient interaction with them, and you're able to ask them questions as if you are seeing them as a PA, right? So this is good practice, good repetition, um, for once you do go out in clinic rotations. We also have OSCEs, which are objective structured clinical exams. So pretty much you stand in front of your exam room, you're given a scenario, you have, a couple minutes just to review what you're going to be doing. You go in and your professor will proctor you in terms of that exam. So you're going to take the full history, you're going to do the full review of systems, you're going to take their vitals and examine the patient, ask them the proper questions, and then, present the patient. So it is stressful at that time, but you'll be well versed and well prepared to trim your 20-30 minute patient encounters to 5 minutes, a few minutes, but for the most part, they just want to make sure that you're able to do everything properly during those OSCEs. It is stressful, but at the same time, it's required by ARC PA standards, which is the accreditation body for the PA schools. The PACRAT, so that's it's like a practice board exam that you're going to take sometime during didactic year, more towards the end of didactic year, to see, how you would fare on the pants. Technically, you should learn everything during didactic year that will allow you to pass the pants. But, obviously it takes more practice and more studying experiences and exposures during clinical rotations as well. And then finally, master's capstone project. So you're going to do your master's thesis because again, PA programs are typically a master or essentially a master's granting program in which, you'll have to do a research project on. And then finally, once you get to clinic rotations, some PA schools will give you your white coat pretty much first day that you step on. Some PA programs like Marshall B. Ketchum gives you your white coat right after didactic year, after you pass everything into clinic rotation. So it all depends. For myself, I felt like I I liked that better, at least for me, because it felt like I earned it. I mean, obviously you earn it once you get accepted, but it feels like, I have to push through didactic year and struggle to be able to get that white coat. And once you get it, it feels good. And then after you become a PA and get your long white coat, you don't really wear it anymore. I barely wear my white coat, honestly. All right. So for clinical rotations, you have that clin prep. So right before you go into rotations, you're doing like a recap of all the skills and procedures that you might see out on your core rotations, which include family medicine, internal medicine or adult medicine, pediatrics, general surgery, emergency medicine, women's health slash OBGYN, and then behavioral health slash psych. So, those are typically the core rotations that RPA requires for all PA programs to have. So you're going to hit one rotation in those with 6 or 7 rotations, and then you're going to have the elective rotations. Some programs have one, some have two. It really just all depends. And for the most part, they set it up for you, and you just tell them like, hey, I want to do a rotation in dermatology or ortho or plastics or critical trauma, whatever it may be, and they'll work to try to get that rotation for you. It's okay if you don't know what you want to do specialty wise before PA school, during PA school, or even during clinic rotations. This is your opportunity to interview essentially as a tryout. If you A, like that rotation, if B, you like that hospital or healthcare system or clinic that you're working at, and also if they like you, right? Um, what was a quick question in the chat? What was my elective of choice? So initially my elective of choice was ortho, but because of COVID, I wasn't able to do that at Kaiser Fontana. And so it ended up being the clinic that I'm at right now. They hired me as a new grad. So I got lucky with that. So occupational medicine and urgent care. All right, so EOR exams. So you're not done with exams after didactic year. You don't have anybody hounding you in terms of studying, and the exams aren't every week or 2 weeks. It's actually going to be at the end of your rotation, whether it's 4 weeks or 6 weeks. You're going to have these end of rotation exams on things that you should have been seeing during that rotation, or that you should have known or expected to know for the PANCE and board exam. All right. So those end of rotation exams typically happen on what we call callback days, in which you return back to campus. You're seeing your classmates for the first time in a while since rotations, because everybody's out doing rotations somewhere else. And then you take your exams and do callback days. Sometimes if your exam is, or if your rotation is far, you're able to do it remotely. And then skills sign-offs. So during your rotations, most PA programs will have a skills sign-off sheet in which you're expected to perform at least one of these different procedures or skills on a real patient out in clinical settings. So whether it's suturing or doing pelvic exams, splinting, casting, chest X-ray or EKG reads and interpretations. You're supposed to be able to do at least one or two of these, and then you get it signed off by your preceptor, who is typically a PA or an NP or an MD or DO, who supervises you during your clinic rotations. A question here: where's the furthest I had to travel for my clinical rotation? Temecula, I believe. So my clinical rotation year was interesting because of COVID. The furthest I was supposed to go to was actually Philly. I was going to do my family medicine rotation out in Philadelphia. But again, because of COVID, they had to pull everybody back. And then I was going to go back to Temecula again, but again, COVID. So my first 2 rotations, it was Temecula and then Riverside, out of like Moreno Valley, Beaumont area. um, at a clinic that I used to volunteer at when I was in undergrad, and then went to ER at St. Jude in Fullerton, and that's when COVID hit. So from there, a lot of rotations just kind of got cut and changed. But no regrets. This is what PA school is like for the most part. We're doing a lot of the hands-on procedures and skills and training to be able to do it in real life and out in clinic rotations and out, when you're done with PA school. All right, that was a lot, I know, but it's about to be a lot more. So right now, why don't we just take a quick, 2-3 minute break. Go ahead and use the restroom, stretch out your legs. I don't want anybody to get a DVT on me. Go ahead and hydrate, whatever it may be, and get ready for this lecture. Okay. I'll still stick around if anybody has, off the side questions.
I had a question.
Yeah.
How did you feel confidence-wise when it came to taking the exams? For like, let's say the end of the rotation exams, did you feel like you could do it, or did you feel like I need to study a little bit more?
Um. So you're always gonna feel like you should have studied more, or like, oh man, I wish I had more time, even if you're studying every day. Um, So for my PA program, you needed at least an 80% to pass everything, even though like the threshold for like majority of PA programs is like a 70%. Reason why they did that was because they wanted us to make sure we were like well prepared to take the board exam, right? So all my modules I was able to pass fine. Um, and the rotation exams, I think a couple of them like I missed by like 1 or 2 points. So if I was in another program, obviously I would have passed. But at Ketchum, it was like, oh dang, I didn't pass this end of rotation exam. Not the end of the world, but you just pretty much have to do like a remediation process. Each program's remediation looks totally different, but it allowed me to reel myself back in and be like, all right, I really got to focus and study because this isn't just for this end of rotation exam. This is for the pants exam, right? So just you'll see like the topics that you missed, right? I don't think you necessarily see the questions that you missed, but you'll see the topics, and then you'll see like because there's just like the memorization, and there's the application, and there's the comprehension, and just different layers like the Bloom's taxonomy hierarchy of questions. And so a lot of them are a lot more in depth. So you'll read what we call a vignette, right? So it's like a 43-year-old female patient presents to the ER with abdominal pain. And then so they paint this picture for you in terms of allowing you to help uh, recall what the patient's going to have and things like that. So you're reading, you're like, okay, boom, I know that this patient's, presenting with like an acute appendicitis. But then the question goes, what's the main cause of it? You know what I mean? So it's just like it throws you in a loop. You might think that you know what they're about to ask, and then they just ask something totally different. Sometimes it is straightforward, like a 2-year-old male patient presents with tugging on his ears and high fevers for 4 days. You look in his ears, his tympanic membranes are erythematous and bulging. So for sure it's an ear infection, right? And it's going to be like, what's the first line of treatment? Right? So you already know, like ear infection, high dose amoxicillin, things like that. But then they might again throw a wrench at you, where it's like, and by the way, they have a penicillin allergy. What would you prescribe? You know what I mean? So you just kind of have to. This is why you have to know a lot, and it just kind of builds upon each other.
Thank you. And then
For
I also
sure.
wanted to know, as far as test anxiety, what helped you?
Um, I don't know. So something that was weird about like my test taking protocol or process or work. I mean, like how I came into an exam This was true of mainly didactic year because I don't think I did this during clinical rotations. Sure as heck didn't do it during my pants, but uh, undergrad I probably pulled maybe like one or two all-nighters ever, right? PA school, I think I pulled an all-nighter before every exam. And that was just the way I worked. Like, leading up to the exam, it wasn't like I was slacking off every single night and day after sorry, I lost me. Can you hear me?
Yeah, I can hear you.
Okay, my bad. So every night after lecture, I would study, right? But I still felt like, man, I need more time. I need more time. So I just kind of like reviewed all my study guides that I worked on throughout that module, and then pulled that all nighter, took the test, and then I was done with it. But the weird thing that I did aside from doing the all nighters, which is also kind of weird, um, so I would listen to rap music, like hip hop rap music. I treat it as if it was like a game, right? So I played sports growing up, football, basketball, whatever. And we would always get pumped up by listening to, hype songs. And I would just like blast my headphones with, all this rap music while I'm like just like reviewing and studying, just to kind of get me in like a game mentality mood, right? And so that was like something weird that calmed my nerves and anxiety. It was just going in with kind of like a little bit of adrenaline and was ready to take it, and got through it. And then as soon as after the exam was over, everybody would have the anxiety of like, oh, did I pass? Did I not? And so after we take the individual exam, then we take a group exam of the exact same test, right? So if your group gets over a 95%, you get an extra 5% added to your individual grade. So it was like a mix of everybody, but luckily when I needed those 5%, I was able to get it. Sometimes I didn't need it, but and sometimes I didn't get the extra percent. So that was the anxiety of after the test itself. And then once we got the email like, oh, congratulations, you passed X, Y, and Z module, I just go home and like knock out, and just kind of recover for that weekend and do it over again, rinse and repeat.
Thank you.
Yeah,
Very
for
helpful.
sure. All right, y'all. You ready for your first quote unquote official PA school lecture? Okay, let's do this. So, anatomy and physiology. Obviously, we're not going to go through every single aspect of it, but this is just a crash course and also more so an exposure, an experience to how anatomy lectures are, and the pace of it and the depth of knowledge that you're going to go into. Okay. All right, so course expectations. Expect y'all to actively participate, engage, and be respectful during lecture sessions. Um, you're more than welcome to eat. You're welcome to ask questions. Just don't interrupt. Just don't make coffee in the back. Find and adapt to your learning styles. So every lecture is going to be different, and all the lectures are going to be different. Some are going to have, bolded words to let you know, hey, this is extremely important. Some of them are just going to be textbook information, and you just have to sift through it. Some of them are going to be one picture, and the lecturer is just going to explain and talk the whole time. So you have to find that balance between taking down notes and possibly recording lectures, and just going from there. So it's a fine balance, but once you get that groove and you get your routine, the next lectures are going to be a lot easier. Okay. So again, this course right here is to build a foundation for your future PA lectures. All right, so every PA lecture, because of ARC-PA standards, requires a learning objective, right? So what are you expected to come out of this lecture with? So I want y'all to understand and be able to correctly utilize anatomical and directional terminology, briefly describe the anatomy and physiology of the musculoskeletal and cardiovascular systems. For this lecture, we're only going to do skeletal, essentially. All right, so excuse me, let's go ahead and start off with anatomical positioning. So when we're talking about patients, excuse me, in terms of, addressing their right side or left side of the body. We want to address that correct body part with relation to the anatomical position of them, right? So anatomical position means the patient is facing forward and their palms are facing forward, hands are out to their side, and they're standing upright with their feet flat. Okay. So this is anatomical position. You've seen it in your anatomy classes if you haven't already. And then in PA school, this is what you're expected to know what anatomical position is. Okay. All right. So some other positions is supine or prone, right? So if a patient is laying supine, they're laying down face up, right? So this is just kind of something that I helped me remember it. So you're laying in the supine position. So the up, the UP is in supine. So they're facing up, right? Prone. So the patient is lying face down. And so think of it as pros do push up. When you're doing a push up, you're facing down, right? And you're pushing up. But think of it based on those, or if you played Call of Duty, prone, when you're trying to crawl and go prone, that think of it like that. But this is also what you're expected to know during PA school. Just so when you're examining the patient, when you're documenting their exams, the patient was lying supine, or whatever it may be. All right, so next we're going to talk about anatomical regions. So the abdomen or the abdominal pelvic quadrants, they're separated into 4 different quadrants. The right upper quadrant is where we have the right lobe of our liver, our gallbladder, portion of our right kidney, and then some portions of the stomach, as well as some tracts of the small and large intestine. On the left upper quadrant, we have the left lobe of the liver, part of the stomach, most of the stomach, honestly. The pancreas is right adjacent to it, and then a portion of the left kidney, the spleen itself, and then again portions of the large intestines. The left lower quadrant, so this is most of the small intestine and a portion of the large intestine. This is a main common area where patients get diverticulosis or diverticulitis, just as a pearl for when you are in PA school and you know that. The left ureter is on that side, and the reproductive organs for females and males. All right, and then on the right lower quadrant, so this is typically where patients present when they complain of right lower abdominal pain. They have an appendicitis, right? So the cecum is a portion of the digestive tract, and as well as the appendix. So those two are located in the right lower quadrant. Again, portions of the small intestines as well, and then the right side of the right ureter and reproductive organs. All right, any questions? All right. So breaking that up, we also have the abdominal pelvic regions, in which we not necessarily divide it into numbers, but into regions, right? So we'll talk about the main ones in terms of the epigastric region or the umbilical region or the hypogastric region, right? So epigastric is above or right near the esophagus, right above the stomach. Umbilical, as you can see right there, right in the middle, where your umbilical or your belly button is essentially where your navel is. 8, your hypogastric, so just right below it. And then a lot of times we'll like to break this down in terms of the right hypochondriac or the left hypochondriac, right lumbar, right inguinal, those regions, just for more so for general surgery purposes. But typically, you won't necessarily need to know all of this. We typically break it up into the quadrants as opposed to the regions, except when we're talking about the ones right in the middle, the epigastric, umbilical, and hypogastric regions. For PA school purposes, for your lectures, you will probably need to know the breakdown of all this as well. All right, so with regards to anatomical directions in terms of, how to describe something. If something is proximal versus something being distal, or medial versus lateral, or superior versus inferior, and left versus right. So proximal would mean it's towards the base, the attached base. So as you can see, that shoulder is proximal to the head, versus the wrist being distal or away from the attached base. So the wrist is distal, compared to the shoulder. Medial, so everything that's midline, when you're coming towards the midline, that's more medial. So for example, your knees, right? Your medial meniscus are the meniscus right, at your knees towards the midline, right? And if you're going away from the midline, those are the lateral. So your lateral meniscus or your lateral collateral ligament. All right. So aside from that, we'll talk about superior versus inferior. So superior meaning above or inferior meaning below. So would it be correct if I said the chest is superior to the kneecap or the patella?
Yes.
Yes,
Yes.
yes, right? Okay, perfect. Or the ankle is inferior to the thigh, So this is just a way for us to know exactly what body part you're talking about, or where the lesion is, or where the scar is, or where the fracture is, right? And then something else that you'll also want to talk about with regard to maybe like a laceration or something else like that. I apologize, my mom's calling. Superficial versus deep, right? So if it's at or near the surface of the body versus if it's deep, a lot more internal to the farther from the surface. Okay. Any questions on the anatomical directions? Good. Okay. So these are the planes that you would be expected to know as well. Sagittal cuts or mid-sagittal and parasagittal. So mid-sagittal would be something right smack dab down the middle, cutting the body in the portions of being left versus right. And then parasagittal would be, kind of moving that line a little bit more towards the left side or the right side to make a sagittal cut. This would be, when you're working with cadavers and, looking at different aspects on a CT or an MRI. Transverse cuts is a horizontal cut or cross-sectional cut. And so a lot of this would be on an MRI or a CT when you're trying to examine, each layer by layer. Think of it as like a stacked layer of the cadaver or body. All right. Then transverse again, this is separating from superior, so something above versus something inferior. And as I mentioned, cross sections for MRIs and CTs. This is, depending on what part of the transverse cross section you're looking at, a kidney might not even appear in your view versus if you go a little bit lower, it might, and you might see, intestines and things like that. So it all just depends on where you're looking. Okay. And then the frontal, that's where you're cutting in front versus or for anterior versus posterior. I apologize. I didn't mention that in the directional slide, but anterior obviously is in front, posterior would be back behind, and the frontal cut would be what separates those two. And then oblique cut. So a lot of times we'll cut, an image in towards at an angle, so that way you can kind of look a little bit more of like a posterior and anterior, while also looking like a little more transverse of a cut as well. Very rarely do we look at oblique cuts for diagnostics with MRIs and CTs. It's typically going to be transfers. It's typically going to be frontal as well. All right. So with regards to body cavities, we're going to have a few different cavities. The cranial cavities that consist of just the brain, and the spinal cavity, which consists of the spinal cord. Those are the only two components that are on the posterior cavity, which again is on the back side, versus the anterior cavity, which is on the ventral side or the front side. This is broken down into the thoracic cavity, and you break that down even more, as you can see on the right side, the pleural cavity where the lungs are, the mediastinal cavity where part of the lungs, in between the apex of the lungs, and then the pericardial cavity. So this is where all the heart issues are, right? So when we have something called pericarditis, it's an inflammation of that pericardial sac, right? So you're looking at the visceral pericardium that covers it, the pericardial cavity, that hole itself, and then the parietal pericardium, which is a lot closer. And as a side note, taking medical terminology is highly, highly recommended. A lot of programs do require it, but being able to quote unquote speak the language is half the battle. Once you're able to, understand these words and use them as best as possible, um, anatomy is so much easier. Ortho is so much easier, and especially general surgery. Knowing your anatomy definitely helps, and knowing your medical terminology helps as well. All right, so the thoracic cavity we mentioned earlier, right? So we have our lungs, we have our heart. In the abdominal pelvic cavity, that's where most of our GI and genitourinary organs are, right? So the stomach, intestines, and spleen and liver all in the peritoneal cavity, and then the abdominal cavity itself, and then the pelvic cavity. So earlier when we looked at the regions, when we showed the hypogastric region, another word we could utilize for that region would be suprapelvic, right? So right where the urinary bladder is, a lot of times when we palpate that for urinary tract infection, that's something to look at. And so when we document it, we'll say tenderness to palpation over the suprapubic region, right? So you can say that, or the hypogastric region. All right, so this is what we're going to focus on for this part of the skeletal anatomy lecture, the vertebral anatomy. So typically speaking, the average vertebral column contains of 26 bones. Of those 26 bones, we have the 24 vertebrae, one sacrum, and one coccyx. So the sacrum itself is about 5 vertebrae fused together to make that sacrum that looks like a shield almost. And then that coccyx, or that tailbone, is typically 3 to 5 fused vertebrae. Depends on people's anatomy. It can be a little bit more it can be a little bit more towards posterior, right? So that is typically what we call the tailbone, and that consists of the vertebral column. But the main parts of it would be the 7 cervical vertebrae, the 12 thoracic vertebrae, and the 5 lumbar vertebrae. So these are absolutely, you need to know this for PA school. C1 through C7, T1 through T12, L1 through L5, and how we discuss the nerves would be the nerve root coming out of L5S1 or L4 L5. A lot of you have maybe heard of that for maybe some of your patients or your parents who have had surgery on their back, who had like a laminectomy or a different type of procedure in which most of the lumbar procedures are done at L4 L5 L5S1. That's just so we know exactly where on the vertebrae it is. Okay, so again, 24 vertebrae for the main column, 7 cervical vertebrae, 12 thoracic, and 5 lumbar. So this is kind of a color coordination as to where you might find it. All right, and then so let's look at the anatomy of the actual vertebrae itself. So you're gonna have the spinous process that sticks out. So if you feel your back, kind of where you push on your spine right there, you're gonna feel that spinous process. So anytime you see process, that means something's sticking out, right? So as you can see right there, the transverse processes are the ones on the side. The superior articular processes, that's kind of coming up towards you. And then the lamina is, connecting the spinous process to the rest of the vertebral body, or the vertebral arch right here. This is the arch that's attached to the vertebral body. The peduncles are, what anchor the arch to the vertebral body. Compression fractures are typically found on the vertebral body itself. Sometimes, very rarely, you'll have a spinous process fracture or a transverse fracture. But this anatomy is more so for, you know, ortho spine specialists or neurologists when, say, for example, you know, their discs are kind of pushing on the nerve roots that go through either that arch right there or out to the side where the transverse process is. Um, but this will all be connected when, you know, you do an ortho lecture and you look at the spine. So this is kind of an X-ray of the cervical spine as well as the lumbar spine. I'm not sure if y'all have had any experience looking at X-rays for the spine. So typically we have a little curvature to our spine in terms of the cervical spine and lumbar spine, as you can see in this picture, right? How it's a little bit more curved. Now this is a little bit more upright. So how we would describe this would be maybe like a loss of lordosis, which means it's losing a little bit of that curvature, right? So, you know, you look at your vertebrae, your end plates, and you know, I love this picture because it you know pinpoints all the different aspects in terms of the spinous process, the lamina, and the body itself. And then, you know, so that way it's a lot easier to see, oh wow, this patient has a fracture in, you know, at the C4 vertebrae or the spinous process of the C4, um, and or a sacrum or a coccyx fracture, you'll be able to see it. Typically, you won't be able to see a sacrum and coccyx or a good picture of a sacrum and coccyx on a lumbar spine X-ray, and you'll need to order, you know, a different one so it shows the sacrum and coccyx itself. Um, but yeah, typically for, you know, any back injury, you'll get a lumbar spine X-ray. Depends on what setting you're in. Maybe you'll get a CT scan as well. All right, so I know that was a lot. How was that?
Good.
Not too bad.
Keep it coming. Keep it coming.
Keep it coming. Y'all are funny. All right, so are we done yet? No, but there's also something else that I wanted to share with y'all with regard to our physiology aspect. And obviously, with that is definitely a lot more as opposed to, you know, what I just showed you. That's a portion of your skeletal lecture for anatomy. Think of that, you know, in depth with regard to the wrists and the hands and the shoulder. So you're doing the anatomy of all these body parts in 1 week, right? So think of your anatomy course jam packed in that 1 week. Or when you do ortho or musculoskeletal, you're doing all these lectures, right? So what I'm going to show you is my physiology study guide. So this right here is what we were expected to know also in 1 week. So as you can see, we boil it right back down into, you know, protons and electrons and covalent bonds and hydrogen bonds and all of this because they want you to have this strong foundation going into PA school to where they can just run through it real quick in a week and then you're able to, you know, get past the anatomy, physiology, and the pathophysiology to be able to build upon, you know, further aspects. So this was how many pages? This was 30 pages, but this is one out of my 3 lectures. I mean, study guides, sorry. Yeah, so what I highlighted in red would be, you know, the learning outcomes, and then I would just put my lectures and then all the slides and different notes on the side, as well as, you know, images from the textbook. I had a way to color coordinate things at that time. And again, this was like my first PA school study guide. And it obviously changed as the modules went through. But again, expectations to know all this stuff in a week. So you're there pretty much 8 to 5. That's why, you know, it's very rare that anybody works during didactic year PA school. Because you're there 8 to 5, 9 to 5, whatever it may be, and then when you get home, you're studying and then using any free time that you have to get down this information. And then that was my practice test. Let's not look at that. All right. So That's the physiology aspect of it, okay? I just didn't want to bore y'all with another lecture like that. But let's go ahead and get into, yeah, so that was that physiology part. And yes, that's essentially what it looks like in PA school. Okay, so now we can get to the more fun stuff. Something with regard to, this boot camp and the lectures and everything. I'm gonna try to give y'all a comprehensive experience in terms of those lectures, some guidance, and these case studies. So that way you can utilize it on your application, on your CASP application as virtual shadowing, whatever you want to utilize it as. Talk about your experience learning about what PAs are, what you should know during PA school, especially when they ask you, well, how do you know that you're prepared for PA school? Obviously, the number one thing is going to be your prerequisites and your strong background and foundation, but also you can let them know, like, you haven't really sat in on a PA lecture, but you've had a taste of it, right? And so, find a way to show that you are a little bit more prepared than you were previously. So again, with these case studies, it's almost like virtual shadowing for you to utilize. So I want you to definitely incorporate that in your application, okay? So this part is going to be a little bit more interactive. We're going to have people read as well, and then we'll get to the tail end of our lecture. All right, so case study number one. Let's go ahead and have Ashish. Do you mind reading this slide for us, please?
Not at all. Mr. Smith, 29 years old, male. Date of injury, DOI, February 4th, 2024. Mechanism of injury, MOI, MVA. Chief complaint, CC, neck and lower back pain.
All right, thank you, Ashish. Can somebody let me know what MVA is?
Motor vehicle accident.
Exactly. Thank you so much. Just so everybody's aware, depends on what specialty you're in, what setting you're in. A lot of people are going to use abbreviations for, a plethora of things. So make sure you're aware of some of these things. Don't make up your own abbreviations too, just so that way everybody's kind of clear. All right. So overall, we have Mr. Smith, a 29-year-old male who was injured yesterday, right? Today's the 5th? Yeah, yesterday in an MVA, motor vehicle accident, complaining of neck and lower back pain. And what is their HPI looking like? So let's go ahead and have Destiny. Do you mind reading the review of systems for us, please? Just the review of systems.
Sure. Review of symptoms is fever, chills, LOC, nausea, lightheadedness, dizziness, headaches, chest pain, urinary incontinence, numbness, tingling, weakness in extremities, and neck pain, back stiffness, and decreased range of motion.
All right, perfect. Thank you so much. So for that first part that Destiny read, so those are the pertinent negatives, right? So patient denies any fevers, any chills, any loss of consciousness, nausea, lightheadedness, dizziness, headaches, etc. But he does have pertinent positives, which are that he has neck pain, he has back pain, he has back stiffness, he's also having decreased range of motions. So can somebody tell me why we would be concerned and why we would ask him if he had any of those, the loss of consciousness, nausea, lightheadedness, and dizziness and headaches?
Trying to rule out other issues.
Yeah. What specifically, Jesse?
Specifically, like what sort of like diagnoses or what sort of issue or like what?
Yeah.
Is
So
that the question? Sorry.
Yeah. So why would we be concerned of those, 5 symptoms with regard to this this injury? Do you want to pass it on to somebody?
I mean, I'll just give it my best shot.
Yeah, sure.
Just we're gauging the severity. Obviously, we want to just rule out any kind of possibly head trauma or anything more serious. That's kind of my first instinct. Yeah.
Okay. Yeah. No, definitely. We want to rule out any head trauma. obviously it depends on what setting we're in, right? Say, for example, we're in an urgent care setting, right? So if he did have any of these quote unquote red flag symptoms, we would send him to the ER because that could be not necessarily just a head contusion or a head concussion. It could be something more traumatic in terms of like a TBI, a traumatic brain injury, or subungual. Subdural hematoma, right? Something a little bit more serious that would be neurological. So that's why we're asking those symptoms specifically. Well, luckily he doesn't have it in this scenario. All right, good job. Now, with regard to asking about the urinary incontinence, numbness and tingling, and weakness in the extremities, uh, Jessica, can you let me know why we're asking about that?
I think it would be just to rule out anything that's other than neurological.
Yeah. So kind of the same thing, right? The top questions were with regards to the head, right? And so the urinary incontinence, the numbness and tingling, weakness would be more with regard to the lower back pain that he's complaining about, right? So these are also red flag symptoms. Anytime that a patient is complaining of lower back pain and they're like, "Hey, by the way, I can't control my urine. It's like it's just going, or I can't feel my legs." That's something more severe neurologically. It's something what we call cauda equina, which the spinal cord ends in what we look at it when we look at it on a scan. It looks like a horse's tail, right? So the cauda, that's where it comes, or the equina part is where we get that terminology from. And anytime something's pushing on those nerve endings, it might constitute or cause some of that saddle anesthesia or numbness or that urinary incontinence, and that's a serious issue. So the reason why we ask for these review of system symptoms is to triage them to make sure, all right, is this patient stable? Do they need to be sent to the ER? Do they need to be sent straight to surgery? So you're asking these things to get an idea of where they're at, right? Anytime a patient comes in with chest pain and shortness of breath, all right, we're triaging them. We're asking them, all right, what other symptoms do you have? Do we need to send you somewhere else with higher acuity workup, or are we okay with seeing you here? All right. So review systems, that's why we always want to take this first. And as Destiny read earlier, the patient's complaining of neck pain and back stiffness and decreased range of motion. So it sounds like it's a little bit less severe. It's more of like a musculoskeletal issue as opposed to something neurologic, which is great, right? All right, good workup, everybody, so far. So let's have Jonathan go ahead and read that pain side of the slides, please.
Of course. Pain 6 out of 10, constantly achy and sore, intermittently sharp, does not radiate anywhere. It gets worse with movement and direct pressure, but gets better with rest.
Okay, and then you could just finish up that treatment part too.
Treatment, none yet.
Perfect. Thank you, Jonathan. So now we're asking, the patient, what's their pain scale? How would he describe the pain? What makes it better? What makes it worse? And has he tried anything yet in terms of medications, any ice or heat, any remedies? So we want to get a gauge of where they're at in terms of their baseline and what they've tried so far and what has helped them, so that way we can help develop a better treatment plan. All right, good job, team. So now let's go ahead and put all of this together, our history of present illness, okay? So when you're taking history and when you're documenting it, there's a couple ways to go about it. One thing that I was taught even in my EMT class and also during PA school is what we call old carts. So you'll create a history of present illness based on this essentially. So onset, location, characteristics, aggravating factors, relieving factors, timing, and severity. So I think we have all the information previously told to us as we read from the ROS review of systems, as well as the history for the pain. So let's see if we can create an HPI. Let's see. who wants to give it a shot in terms of giving us some of that, creating a history of present illness?
I can try it.
Okay, go for it, Natalie.
So he describes a sudden onset located in his neck and his back. He describes it as sharp and intermittent pain that gets worse with movement and with pressure on his back. And some relieving factors are with rest, it does alleviate. And it happened yesterday, and he would rate his pain as a 6 out of 10.
Okay, good, good. Thank you very much, Natalie. Anybody want to add something else?
I could add stuff.
Okay, go ahead, Isabella.
I think we also need to mention who Mr. Smith is. So Mr. Smith is a 29-year-old male presenting to the urgent care clinic for his neck and lower back pain as the chief complaint. And then he states that he received the injury on I learned you have to put the exact date. So February 4th, 2024,
Okay.
due to a motor vehicle accident. And then
And then the rest of the stuff that Natalie said.
yeah, and
Yeah.
also including the stuff that he said he doesn't have, like no denies fever, chills, loss of consciousness, and then yeah.
Okay, good, good additions. Thank you, Isabella. So, yeah, Ashish, go ahead.
I had a question for old carts. Is the
Mhm.
D? It's not listed. Would that be the date of injury?
Ah, my apologies. That is a typo. So it's typically the duration, so like how long it lasts for, right? So, would be like intermittent, right? Some, what we talked about for that. So onset would typically be like, 2 days ago, yesterday, or, suddenly early this morning. So that's how we would go with the timing, or like the onset of it. The D, yeah, it's typically duration of like the how long the pain lasts for, and then the timing is like when it comes. Does that make sense? Okay. So, but yeah, thank you for pointing that out, Ashish. Let's see. Next. Okay. So this is kind of how the HPI would be. It, it, the two ladies are perfectly correct when they were sharing it. Let's go ahead and have Richard. Do you mind reading this HPI for us, please?
Yeah. Mr. Smith is a 29-year-old male who presents today with complaints of neck and lower back pain. He was involved in a motor vehicle accident in which he was rear-ended while at a stoplight. He reports of 6 out of 10 pain in the neck and back that is constantly achy and sore and intermittently sharp. Pain is worse with movement and direct pressure and relieved with rest. He has not tried any medications or treatments yet. Denies any LOC, headaches, nausea, lightheadedness, dizziness, or changes in his vision. Denies any, how do you say that?
Cauda equina.
Cauda equina symptoms.
Perfect. Thank you so much. So one thing here that I would add would be what Isabella mentioned, the date of the injury, right? So it happened yesterday. So he presents today, but how long has the pain been going on for? So I would say like 1 day or since yesterday, or MVA, or he was involved in an MVA yesterday on 2/4/2024. But overall, this has everything that Natalie talked about, has everything that Isabella talked about. Especially the pertinent positives, pertinent negatives, right? Cool. Thank you for reading that, sir. All right, now for the physical exam, right? So we definitely want to go through and document how the patient is, make sure they're stable and everything. Who wants to give this a shot and read the physical exam?
I can read it.
Okay, thank you, Araceli.
So physical exam, general alert oriented ×3, no acute distress, head, atraumatic, normocephalic. Eyes, extraocular motors, EOM, intact. Pupils equally round, reactive to light and accommodation, PERLA. ENT, normal hearing, TMS intact, no battle signs, no raccoon eyes. Skin, dry and normal. Palm, normal respiratory effort, lungs clear to auscultation.
Auscultation.
Auscultation, thank you.
Mhm.
CTA bilaterally, BL. Nervous, normal gait, reflexes intact. CV, regular rate and rhythm, no murmurs, normal cap, refill. Psych, normal speech, mood and judgment. Cervical spine, normal appearance, no ecchymosis, arrhythmia,
Mhm.
or
So
deformities.
yeah, ecchymosis, so no bruising, and then erythema, so redness, and then no deformities. Okay.
Okay, thank you. Limited range of motion on all planes, flexion, side rotation, tenderness to palpitations, TTP, over the spine at C4, C5, and paracervical muscles and trapezius muscles. Lumbar spine, normal appearance, no ecchymosis, erythema, or deformities. Limited range of motion on forward flexion and extension, tenderness to palpitation, TTP, over paraspinal muscles and SI joint, none over spine, negative straight leg raise.
Perfect. Thank you so much, Araceli. So, one thing that I wanted to correct you and bring to your attention. So, with the tenderness to palpation, right? So, palpation is when we're touching the patient, when we're feeling the patient. Palpitation is, our heart having palpitations, right? So, we just want to be sure we clarify that, especially, in PA school. A lot of my classmates did that too, so don't worry about it. This is your first time reading it, so that was great. Anybody have any questions with regard to any of this documentation for the physical exam?
I have a question.
Yeah, go ahead, Jesse.
Negative straight leg raises just
Mhm.
mean he can't, raise his leg. What does that mean? Just negative straight leg
Yeah,
raise. I
yeah,
haven't heard that.
great question. So it's a test that we would do to make sure that there's no radicular pain going down the lumbar spine. So the patient would be lying supine, right? And we would raise the opposite leg. And if it was a positive straight leg raise, he would have numbness and tingling going down to his calf on the other leg. And then we would switch the sides and do that test as well. So next lecture, I'll try to find a picture or a video that I can show with regard to that specific test itself. Okay. Anybody else have a question? Who knows what a battle sign is or a raccoon eye, and why is that important to document?
I think raccoon eyes are like dark circles under the eyes, right? And they usually appear like after a head injury or something like that.
Yeah, exactly. So it's not necessarily, our normal bags under our eyes. It's actual like bruising that looks like raccoon eyes. And those are that, and then the battles sign, which would be like back behind the ear area in that mastoid region. It would be more signs leaning, like what was mentioned earlier, to a traumatic brain injury, right? So if there's bruising in that area, you definitely want to be concerned about it. Great. And then something else that I would add to this physical exam that I didn't mention would be examining, their cranial nerves, making sure they're okay, right? So I would do like cranial nerves 2 through 12 intact. So I would do a test that checks all their cranial nerves, make sure there's no, serious head injury, especially with the motor vehicle accident and patients are complaining about cervical pain. I just want to make sure there's no whiplash action. Okay. Itzel, yes, go ahead.
I was just curious why it said oriented times 3.
Yeah, great question. So when we ask a patient, say for example, we're rolling on scene, EMS and EMTs, or if the patient's in the ER, we would ask them, do you know your name? Do you know where you're at? What time of day it is? Things like that to make sure they're oriented to where they're at in that specific setting. Just make sure there's no confusion or loss of consciousness or things like that. All right.
Thank you.
Yeah,
I
of
have a
course.
question.
Yeah, go ahead.
I'm familiar with Pearl, but accommodation, what's that mean at the end of it?
Yeah, so reactive to light and accommodation means so once their eyes are accommodated to the light, that they change in the sizes, right? So when you shine a light in their eye, it typically constricts, right?
Hmm.
And then so when you're not shining the light anymore, it typically goes back to being normal pupil size. So that's what the accommodation would be, making sure that when the changes in the light happens, their pupils are constricting and opening back up normally.
Thank
As
you.
far as, sorry, as far as
Yeah.
cardiovascular, what does normal cap refill mean?
Normal cap refill. So normal capillary refill would be, we're checking their fingers and extremities and their toes just to make sure that there's good blood supply going down their fingers and then to their finger tips as well as their toes.
Thank you.
Great question though.
Could you clarify what you mean by oriented times three? What does the times three stand for? Is there like a scale that it's referring to?
Yeah, so it's almost like what we were alluding to earlier with regard to asking those questions, right? Sir, do you know your name? Do you know where you're at? Do you know what day it is? So that's typically, it depends on what county they're at. Sometimes, it's A&O or alert and oriented times three. Sometimes it's A&O times four. It just depends on how many questions they ask them. But if you're doing a health history and they know exactly what's going on and things like that, and they're not disoriented or confused, then yeah, we can do A&O times three.
Just clarifying,
Mhm.
under TMs for ENT, does that stand for tympanic membrane? Just making sure.
Yes, Jonathan, exactly. So tympanic
Got it.
membranes, again, it's a possible head trauma, right, with that motor vehicle accident. So we're looking in their eardrums, making sure that there's no rupture of their eardrums, right? No fluid back behind the ear or bleeding back behind the ear. That's very rare, but those are again along with the TMs and then the no battles sign and the no raccoon eyes, we're less likely to have a traumatic brain injury. Okay. Perfect, perfect. All right, great job, everybody, with this physical exam and great questions. All right, so diagnostics. What do y'all want to do? What do we want to order as PAs?
Probably an X-ray.
X-ray, nice.
No.
Yeah. So remember we're in an urgent care setting. What kind of X-rays do we want to order?
Cervical
A
spine.
Perfect. Cervical spine. Somebody said that. Yeah. And what else?
Lumbar.
Perfect. Yeah, let's go ahead and get some baseline X-rays of it. Make sure there's no, fractures. Make sure there's no movement of the vertebrae itself. What would we explain to the patient if they're, complaining about like a disc herniation, or if they're asking about it?
So what's the question exactly?
So, say for example, the patient's like, okay, well, you're gonna get the X-rays. What is it gonna show?
Only bones.
Only bones, right? And it's not gonna show any what?
Tissue.
Tissue or
Um,
muscular.
Where
Yeah,
yeah.
soft
A
any
disc.
any
Hair.
soft tissue, any nerves, any discs, right? We're not going to see that. We could see a little bit of the joint spacing, right? So if the patient was a little bit older, we could see that the space between the vertebrae are a little bit decreased. As I tell all our patients, time and gravity are undefeated. We're going to get arthritis and we're going to shrink down a little bit. But yeah, I would just let them know, hey, we're going to get a baseline X-ray of your cervical spine and lumbar spine. It's not going to show any soft tissue issues, but based on our physical exam, it doesn't appear that we necessarily need to do an MRI or a CT scan right now, which is a great thing. But if for example this patient came in and then they're having that radicular pain and the neurological deficits that we were talking about with those red flags, yeah, I would definitely consider sending them out to the ER to get maybe a CT scan, maybe a CT scan of the head, just make sure there's no hemorrhaging, right? But overall, yeah, let's go ahead and get some X-rays. So yeah, say we get the x-rays and those x-rays were kind of what we saw in earlier lecture with regard to, you know, no fractures, no malalignment. It's just more so that what did we call it? That loss of what? Anybody remember? So loss of lordosis, right? Typically we have that curvature to our cervical spine and our lumbar spine, but if there's that little bit of loss of lordosis, it's a little bit more straight up. And what would be maybe a possible explanation for that? So
Would it
let's
be, I'm sorry.
no, go ahead, go ahead.
Maybe just like their posture, or like just if they didn't know they had their spine, oh, they had that loss of lordosis before getting the x-ray, maybe seeing it now, it could be their
Posture? It could be, yeah.
or
It's
previous injury.
it wouldn't necessarily show too much of a previous injury, but think more acute, right? So he just got in a motor vehicle accident. He hurt his neck and his back. On the physical exam, let's go back to that, right? So we're palpating over the spine and paracervical muscles. So on the side, those muscles to the side of his neck, the trapezius is a little tender when we're pushing on it, and then tenderness palpation over the paraspinal muscles. So something else that we could have documented on this physical exam would be maybe he had some muscle spasms, right?
Mm.
So that muscle spasm, our muscles are kind of it's a catch-22 because it's protecting our spine and our body, but in a way it tightens up our muscles, and therefore we lose that loss of lordosis because of the muscle spasm. Does that make sense?
Yeah, it does.
Perfect, perfect. So yeah, that loss of lordosis could be just because of, you know, his loss of his muscle spasms that are tightening up his back and keeping it a little bit more upright as opposed to being relaxed, and you know, kind of what Araceli was alluding to with the posture, right? But it's more of an acute issue as opposed to something chronic. Yeah, Paulina, go ahead.
Could it also be due to like other accidents or other trauma?
Um, I wouldn't necessarily attribute it to that. If, for example, he just always had bad posturing his whole life,
Mm-hmm.
maybe, but you would also kind of see how he's presenting, right? If he's kind of just like stiff and upright the whole time, and yeah, you would kind of see that on the x-ray. Um, you could also possibly on a different view see if he has any underlying scoliosis or kyphosis, but for the most part, you know, we're just checking to make sure that there's no fractures, right? And aside from that, you know, that loss of lordosis, that straightening of his spine, would be a little bit more consistent with that mechanism of injury and him being in that car accident, right?
All right, thank you.
Yeah, no problem. Good question. So, all right, so let's go ahead and treat this patient. Let's treat Mr. Smith. What would we like to do as PAs for treatment? Go ahead, Richard.
So since we're assuming it's acute and it's not something like serious for surgery or anything like that, maybe we'll just give them something for the pain, so some type of medication, and then like referral to like physical therapy,
Yeah.
somewhere like that. Yeah.
Okay, sounds good. Sounds good. What medications do we want to give him? What do we want to try?
Ibuprofen? I don't know.
Okay. Yeah, ibuprofen's good. Somebody else want to share? What dosage do we want to give him?
600 or 800.
Okay. Yeah. Depends on his pain level. I typically like to wait for 800 milligrams if like they're in excruciating pain and they, you know, don't have any underlying issues. But yes, I usually go around 600. We can go around 400 as well. If he's saying, you know, I don't like to take medications too much or I don't have too much pain, I can bear it, we can just go with the over counter strength of 200 milligrams. Natalie, go ahead.
Oh, was that the correct answer for like ibuprofen? I was gonna say a lot of times people do like Tylenol and ibuprofen together. That helps a lot. I don't know what the dosage is, but like I see a lot of times people are taking like 600 and 650, somewhere around there.
Yeah, no, that works perfectly fine. Actually, there's studies, and I do this too in terms of, When patients are asking for pain medication, I never write for narcotics, just because it's not in my, it is in my scope. I can write it. I have a DEA license. I'm more than capable to, but it's not in my setting. Like if they need a narcotic, they need to go to the ER if they're in that much pain. But there are studies that show, when you take ibuprofen and Tylenol in conjunction, because they're two different classes of medications, right? And two different mechanisms of action. They do work pretty well in terms of balancing and controlling patients' pain level. So great point, Natalie. Nada, go ahead.
I would also say that a muscle relaxer would be beneficial in this case.
Yes, absolutely. So, say for example, this patient's never had a muscle relaxer before. I would educate them on, taking the medications. I would caution them against what? What would y'all want to say?
Drowsiness.
Drowsiness,
Oh.
driving, right? Things like that, operating machinery, right? I've had patients, big old dude, like 6'3", 260. He'll take 5 milligrams of cyclobenzaprine, the muscle relaxer, and just knock out, and he'd be gone. And I've had little old ladies take 10 milligrams and be totally functional. So it hits patients totally differently. So you definitely want to start patients on the lowest dose if possible, educate them and caution them with drowsiness and making them feel a little sedated, right? So aside from just prescribing these medications, you also want to educate these patients in terms of taking these medications, when to take it, how not to take it, right? So you're counseling these patients on how to utilize the tools that you're giving them to feel better and to get better and improve their quality of life. All right, Itzel?
I just wanted to ask that we wouldn't prescribe any nerve medication like gabapentin because there is no signs of radiculopathy.
Yeah, exactly. And aside from that, it's more of an acute issue. If he was having, months and months of back pain that's radiating down to his toes and things like that, yeah, maybe we can add on a nerve medication. But for the most part, I would caution against it in this setting. All right, great question. So yeah, to finish it up, I would put some heating on there. When I prescribe heat for patients to put on their muscles, what I'll tell them is, the heat is going to increase the blood flow to that region and activate the muscles. So it's not so tight and tense, and it helps to relax it. Ice for something more acute. So I would say for the first 24 to 48 hours, maybe even 72 hours, they can ice it to increase any swelling and inflammation. They can alternate between the ice and the heat. They can do the ibuprofen that we talked about, the Tylenol, the acetaminophen that we talked about. You can do either the 325 milligram, the 500 milligram, which is extra strength already, and then the 650 milligrams, which is also extra strength. And then the cyclobenzaprine 5 milligrams, which is QHS, which is right before bedtime, essentially. I've had patients be prescribed by other providers, 5 milligrams cyclobenzaprine every like 8 hours. And I'm like, whoa, if I take a 5 milligram cyclobenzaprine, I'm knocked out. So I wouldn't typically prescribe that multiple times during the day, especially if patients that need to function and whatnot. Nada, go ahead.
Would there ever be a time where you would advise against heat or ice packs in like any case?
In any case,
Or one or the other?
I would prescribe it for the patient and have them try it. And whichever one provides more of a relief, I would say continue that. I would give them both and just explain to them, this is for this purpose, this is for this purpose. I've had patients where, I prescribe both and they're like, actually the ice works a lot better, it makes me feel better. By all means, go for it. So, you're not, this is something that I want y'all to learn too. This is a team-based approach, right? So the patient is very much involved in this treatment plan as we are. We can advise them on it. We can say, I want to prescribe you this, but what do you think? Do you want to take this medication? Do you want X, Y, and Z? You're providing the resources for them, but it's going to be ultimately up to them to utilize and to take, right?
Thank you.
Yeah, for sure. And then I think Richard might have mentioned it earlier, possibly physical therapy referral if we want to work on getting that range of motion and mobility. So we'll go ahead and do that. And then, of course, strict ER precautions. If at any point he has any of those red flag symptoms, go straight to the ER. All right. Cool. Great job on this case study. Any questions? No. Okay. So this is the last component of the lecture. We'll make this pretty fast. And then we'll wrap up for the evening. But I really want you, if you haven't already thought of your why, to think of it now. I don't want you to have a clear-cut answer by the end of this boot camp, but I want you to really start thinking about it. Really hone in on why you're doing what you're doing, why you're taking the prereqs that you're taking, why are you putting all these hours of studying, why are you getting all these hours, working minimum wage to $25 an hour pre-PA patient care experience jobs. Why are you shadowing? Why are you in this boot camp, right? What is the main reason why you want to be a PA? So I want y'all to realize, if you're trying to become a PA for that Instagram facade of like thousands of followers and making reels and just like showing the highlight at life of being a PA, it's not all sunshine and rainbows. I 100% guarantee you. During PA school, I had my lows and I had my highs. I had numerous scholarships and I've had issues with classmates or professors, whatever it is. It's not all that it's cracked up to be. It's all not all, like I said, sunshine and rainbows. It's tough. It's tough getting into PA school. It's tough during PA school. It's going to take everything that you have to get through it, and even then, it's not over. It just because you pass with the pants and get your PA job, it doesn't necessarily mean it's the perfect life. You'll make a huge difference in so many patients' lives on a day-to-day basis, but there are going to be those patients that hate me, that don't agree with my treatment plan, that don't like how I am. Um, I've had people say that I have quote unquote really good bedside manner. I've had patients to say I never want to see him again. You can't make everybody happy, and like I said, it's not all perfect. It's not like how it is on Instagram. You can't put a filter on how you are in real life as a PA. I just want to reiterate that. Why else not to do it? The six-figure salary. As we saw earlier, what the median average salary was about like $121,000. If you want to go in for the money, go day trade, go do investment banking, go be a lawyer, do something else. You can make easy money without putting the time and effort into going to school. Why would you suffer and put yourself through this just for the money? So if you want to become a PA, don't do it for the money. Like I said, it will change your trajectory in life. It will make you and your family a lot more comfortable, financially. But at the same time, this isn't what you go to work for. This isn't what you make make a difference in a patient's life for, right? Don't become a PA because it's quote unquote easier to get into than medical school. Statistics wise, I think the percentage is maybe half of what it is for medical school acceptance. It's anywhere between 3 to 5% acceptance for PA schools, and it's probably getting a lot more competitive, a lot harder to get into. The word is out there, people are applying, and it's not any more easier to get into medical school than people think. So I want you to make sure that's not a reason why you want to be a PA either. And neither is it a backup plan to as a career as a doctor. If I've actually come across a couple personal statements where I was editing with my PA resource in which people talked about they were in medical school, they got kicked out and decided to apply to PA school and didn't give a valid reason as to why they really wanted to become a PA school. So it seemed like it was a backup plan for them. Like, well, I can't do that, so I guess I'll just be a PA. Or like, oh, if I don't get into medical school, I'll just be a PA or whatever it is. I don't want you all to have that mindset. If you want to be a doctor, go be a doctor, go to medical school. That's not a problem. But if you truly want to be a PA, don't see this career as a backup plan. Not gonna lie, there have been ample times where myself or other colleagues and classmates, thought about medical school, and for myself, I never looked back. Once I decided like PA was the route for me, um, I see it as my calling, and it was really, in my blood. My dad's a PA, and as much as he told me not to come into medicine, or if I go into medicine, become a doctor, I didn't listen to him. I knew that I wanted to become a PA, and I don't regret my decision one bit. And lastly, I know it's kind of confusing to say that, quote, you want to help people and that's why you want to be a PA. That's not a good enough reason. You can help people as a teacher, you can help people as a social worker, as a firefighter, as a nurse. So why specifically do you want to be a PA? Not a superficial reason as to, you want to help people. Okay? So some possible reasons: collaboration with others on the healthcare team, improve the quality of life of patients. The ego or title is not gonna, be the reason why you want to become that. If you want to be, the highest ranking medical person in the clinic, and you want everybody to respect you and call you doctor this or whatever, that's not why you want to become a PA then. Flexibility to grow and learn in different specialties. If you want to be what we call the medical stem cell, where you can pretty much grow into any other role, this is why you want to be a PA. And if you also want a fulfilling career in the healthcare field as a clinician with the quote unquote C-star story in mind, then this is why you want to be a PA. So I ended off with this C-star story. I think we'll leave the personal statement aspect into the next lecture, but I just want to finish on this again because it's kind of getting late. So there's this folk story where there's this beach full of thousands and thousands of sea star or sea fish or starfish, whatever you want to call it, just out on the shore, right? There's this old man. He's just picking up one sea star at a time. He's throwing it back into the ocean, picks up another one, throws it back into the ocean. And this little boy walks up to him and says, "Sir, why are you throwing all these sea star back into the ocean? Like, why are you picking up one by one and throwing it in?" And he said, "Well, if the sea star, you know, aren't in the water by the time, you know, it's before they get dried out, they're gonna die. They're gonna be out on this beach on this shore, and if they're not in the water, they're gonna die." And the little boy said to him, "Well, there's like thousands of them on this beach. You can't save all of them. You can't make a difference." And he said, "Well, I can make a difference in this sea star's life." He throws another one in there and then picks up another one. He says, "I made a difference in this one." He throws it in there. So just as a parallel, we can't save every single patient and we can't save every single life, but the ones that we are able to encounter and the ones that we're able to um, be a part of and be, on their healthcare team, those are the ones that we are able to make a difference for. So don't lose sight of that. Don't take that for granted, because at the end of the day, like I said, we can't save everybody, but we can make a difference in the one life that we do touch. All right. So thank you all for the first lecture. I hope you all enjoyed it. Please feel free to recap with the PDF that I sent, or the lecture that I'll send later on YouTube. But any final questions before we wrap up? No, we're good. Okay, cool. So y'all have my email. Feel free to ask me whatever questions, and then if you want me to kind of go over something for next week, we can definitely do that. Next week's topic, we're gonna essentially the same format, but we're going to be talking about the PANTS exam, the board exam that we have to take at the end. So what are the lectures? What's the breakdown of each module and each topic, and how does it break in terms of percentage? Then we're going to review chief complaint and review of systems a little bit more in depth, kind of how we did with the history of present illness today. And then we're going to go through cardiology. So that one marathon question or that topic that we were talking about, I'll definitely share a story with that, and then we'll go over a cardiology lecture, and you'll see how that goes. Then we'll do another case study related to that module that we're covering, and then the closing lecture is going to be about trusting the process. Okay. All right, y'all. Thank you again for your time, and have a good rest of your week. Stay safe out there if you're, driving in the rain and all that. I appreciate everybody's time, and have a good night. Okay.
Thank you.
Thank you so much.
Thank you.
Of
Bye.
course.
Thank you.
Sure.
Good night.